Today to talk about PRRT or radioligand therapy, specifically in neuroendocrine cancer. I've talked about my talk, the good, the bad, and the not so ugly, but certainly we want to consider all aspects when it comes to radioligand therapy. So here are my disclosures. But I have one more disclosure to make, and that's I'm a medical oncologist. So please keep that in mind. This is a multidisciplinary area involving radiation oncology, nuclear medicine, medical oncology, and the whole NETS team, to be quite honest. So certainly you're hearing it from my perspective, but this is a team effort here. Okay, so our objectives today, when we think about radioligand therapy, I like to review the role radioligand therapy or PRT. The reason I use the term radioligand therapy a bit more is PRT stands for peptide radio-receptor therapy, and there's some non-peptide radioligand therapy starting. So the RLT term is a little bit more inclusive, specifically in the role of neuroendocrine neoplasms. I also want to discuss the latest clinical data on the use of RLT and PRRT in neuroendocrine neoplasms to assess that balance between clinical benefit and possible toxicity and where that stands, and to explore opportunities. Where is the field going and where are we going to move forward? I think this is something we're going to hear more and more of. In the neuroendocrine world, we become familiar with this, but outside of neuroendocrine, prostate, and moving forward, we're going to continue to see this more and more. And I think 10 years from now, we'll have multiple tumor sites be using this type of therapy as a way of treating cancer. So, many people ask, what is PRT or radioligand therapy? Again, as a medical oncologist, the way I think of this is almost like a key and a lock way. You have a target ligand that binds selectively to markers on target cells. In the case of neuroendocrine neoplasms, we have a nice marker called SSTR2, somatostatin receptor 2, which is expressed in many, but not all, but many neuroendocrine cancers. And therefore, it can be manipulated to attach a decaying radioactive isotope that can damage cells and cause cell death. And the way it really works is you have the somatostatin receptor, you have a radioactive substance attached to some version of a somatostatin analog. So you have a lock and a key, they attach, and then that radioactive treatment attaches to the neuroendocrine cells. Once it's inside, it slowly decays, and then we see the cell death, and that is able then potentially give more cell killing to the neuroendocrine cells specifically and try to avoid some of the healthy tissue around it. There's multiple types of peptides and multiple types of isotopes that we can use. What we're going to talk about primarily today is 177 lutetium, although we will, which is a beta therapy, but we will talk about alpha therapy as well. So briefly going to summarize, where do we start from? This treatment has been used in different parts of the world, especially Europe and Australia, probably much longer than North America. And this study was published in 2008 in JCO. And for those of you who are familiar, you'll know that JCO really doesn't publish retrospective series. This was a rarity for JCO to publish a retrospective series. And the reason for this was simply because there was so much talk about this therapy that I think they wanted to at least put it out there for the North American audience. So this was a Rotterdam experience at the Erasmus Cancer Center, where they pioneered some of this work. They looked at 504 patients retrospectively, over 1,700 in treatments, but they were only able to assess efficacy in 300 patients. This was the number of patients, this was the composition of the patients, the 310 patients that they looked at from an efficacy point of view. A very hodgepodge of patients, heterogeneous, a very mixed population. So I think we need to take it all with a grain of salt, but it was fairly representative of what we would see in gastroenteropancreatic or GI neuroendocrine tumors. This was the big finding that they showed, and right now this would be not surprising and certainly wouldn't get published, but I think at the time this was the first proof of principle that on a population of neuroendocrine patients using this treatment, if they had a response, whether it be a stable disease or whether it be a partial response, they lived longer. Now, again, there's a lot of confounders in this retrospective data set, but I think this was the first proof of principle that was being done to help convince audiences that this treatment actually made sense. When they looked at factors that potentially affected positive response. Well, obviously treatment outcome made sense, but other things as well, the type of liver tumor, baseline weight loss. So generally patients who had better performance status seem to do a bit better, but also having functionality, they've proved better, which also indicates that this probably helps with the tumor secretion of neuroendocrine cancers. So as I mentioned, they only looked at efficacy of 310 patients. They showed a 2% complete response retrospectively and a partial response of 28%. They defined something that we commonly don't use in oncology called a minor tumor response, which was somewhere between 10 and 25% response, but they also quantified that at 16%. And again, in this very heterogeneous population, the median PFS was 40 months and the median overall survival was 128 months. Toxicity was a concern, and they did report a 3.6% rate of grade 3 and grade 4 toxicity. They reported that 4 of their patients developed MDS. That was slightly less than 1%. They had non-fatal liver toxicities in 3 patients and renal toxicity in 2 patients. Now, of interest, a fair number of their patients had nausea and vomiting, and this was our first indication that it was actually the amino acids that are being given for renal prevention, renal toxicity prevention, that were causing this nausea and vomiting. And in fact, I had gone down and I did some work in Australia early on, seeing how they were doing radioligand therapy at Peter Mac, and it was very interesting to see. Like at that time, these amino acids weren't as well developed as they are now, and as you shut off the amino acids, the nausea and the vomiting would almost stop, within minutes. And so this is very different than from a medical oncology point of view, where we think of extended emesis and days. This is really transient that they were finding nausea and vomiting. So at this point, there wasn't any randomized trials. There was a lot of interest in this therapy, but there wasn't a lot of randomized trials. I think is just ask people if they could mute their thank you. The interest, I think, is manifest by, if you're seeing now, we've had a lot of large pharmaceutical companies get involved and buy up smaller companies to have a footprint in this area. And this was the first randomized trial that was done. It's called the NETTER-1 trial. The NETTER-1 trial was looking at the efficacy of Lutathera, which is 177 lutetium dotatate, compared with high-dose octreotide. And so these were patients who had small bowel, midgut neuroendocrine tumors, who had progressive disease under standard first-line therapy, which remains as is today, a standard dose of a somatostatin analog of 30 milligrams, randomized to receive lutetium dotatate while continuing octreotide versus high-dose octreotide. And the endpoint of this trial was progression-free survival. Inclusion criteria, as I mentioned, these were patients who had grade 1 or grade 2 disease. They had to have midgut, non-operable or metastatic disease. They obviously had to have somatostatin receptor positive disease because that was the target, and they included functioning and non-functioning patients. This was the primary endpoint, the progression-free survival. This paper is published in the New England Journal of Medicine. A hazard ratio of 0.21. So that means a 79% reduction in the risk of death or disease progression. And, I will say that a study of this magnitude, almost 230 patients, with this sort of hazard ratio, it really is a spectacular finding. And if this was breast cancer or another more common cancer, we probably would have seen this on the front page of the New York Times. But this really has changed the landscape completely of how we treat neuroendocrine neoplasms. On the NETTER-1 trial, and this is important as we go forward, you'll see the overall objective response rate was 18%. Now, again, this is a select group of patients. This is midgut patients who would progress on somatostatin analog, but the objective response rate was 18%, despite that big difference in PFS. What did we see with toxicity here? Well, as I mentioned, we still did see some nausea and vomiting, but I will say that these rates have come down as we continue to develop amino acids, lower rates than what we saw in the Erasmus experience. There was some diarrhea and abdominal pain, and that is to be expected, especially when octreotide LAR. There's actually more in the octreotide LAR arm than in the lutetium alone arm, or lutetium plus octreotide arm, pardon me. And then when it came to blood or lymphatic disorders, we saw some thrombocytopenia and some lymphopenia. One thing that was quite interesting to come out of the NETTER-1 study, there was a lot of debate about renal toxicity and what the extent of renal toxicity is. And what this study showed, I think, laid to rest the ongoing debate, was that with good amino acids, renal toxicity wasn't a large issue, and renal function can be preserved with amino acid protection of the nephrons. When the study looked at health-related quality of life, it actually showed an improvement with lutetium dotatate in time to deterioration in global health status. And when we looked at the subscales, and the subscales and the global health status is defined by a score movement of more than 10, which is considered clinically meaningful. In physical functioning and role functioning, there were also an increased time to deterioration of quality of life. So not only was this helping prevent tumor progression, but it was actually improving quality of life in the neuroendocrine tumor patients. Everybody inevitably asks about the overall survival. This is the updated overall survival. And as you can see, initially there was some difference, but then the curves came together. And this is primarily due to issues like crossover, due to subsequent therapy. Neuroendocrine patients, it's not uncommon for them to get 5 or 6 lines of therapy. So I think that is a key point here. So, even with a hazard ratio of 0.21, we have not shown an overall survival difference in neuroendocrine cancers. And there's a lot of consensus within the neuroendocrine community that overall survival is not a meaningful endpoint because of all these reasons, and progression-free survival is really the endpoint we use to move forward. So this trial, the NETTER-1 trial, after that got approval in the United States and got Health Canada approval for the treatment of small bowel and pancreatic neuroendocrine tumors. We now have funding in Ontario for both small bowel and pancreatic neuroendocrine tumors, but there was some debate because the trial itself didn't include pancreatic neuroendocrine tumors. So I wanted to bring up this one trial from France called the Ocular-Random trial, which looked at patients who had pancreatic neuroendocrine tumors who'd been pre-treated and had progressive disease, and they were then randomized to receive lutetium dotatate versus to receive sunitinib, which was a common oral agent we use for pancreatic neuroendocrine tumors. Now, this study, interestingly, had an endpoint of a primary endpoint at 12 months, PFS at 12 months, which is probably not the common endpoint we see in most of our trials. And I think this was done primarily to keep the numbers at a feasible level. But nonetheless, what they did find is that there was a difference between 80 and 20%. So it was a positive trial about progression at 12 months, showing an advantage to the lutetium dotatate arm. Here, we can see the progression-free survival data, which I think many of us would be much more familiar and comfortable with. And you can see here that, in fact, the median difference between the PRRT arm and the sunitinib arm excuse me, was 20.7 months versus 11 months. Now, this wasn't, again, to be clear, its primary endpoint, but nonetheless, there did seem to be an advantage, as well as it did meet its primary endpoint of progression-free survival at 12 months. And I think what this really does is just help solidify our understanding of the NETTER-1 trial, which is that it looks like in all gastroenteropancreatic or neuroendocrine tumors of GI origin, PRRT in those patients who have their SSTR receptors, which is the vast majority of patients, is a very effective option. When we look at safety and tolerability, they didn't report their safety in great detail, so I think it still did leave some questions. They reported some lymphopenia, but as much in the sunitinib arm as we would see in lutetium dotatate arm. There was some grade 3 AEs. They didn't report on their specific MDS rate, at least as of yet. So I think we didn't get a lot of new information from the Ocular-Random arm based on the safety and tolerability from what we knew already. So really, this study here, which we're really proud has been led by Sunnybrook. So you could see here, Sten, myself, our whole clinical trials team. We were the global leaders in this study. It's called the NETTER-2 study. It just got published in Lancet last week. So this is really a great achievement for Sunnybrook overall. And I had the pleasure of presenting these results at ASCO GI. And this study was the next large randomized clinical trial that's practice-changing in terms of radioligand therapy. And it is called the NETTER-2 study, follow-up in NETTER-1, and looked at the efficacy and safety of lutetium dotatate in newly diagnosed patients with advanced grade 2 and grade 3 well-differentiated gastroenteropancreatic neuroendocrine tumors. So this was the first trial ever looking at first-line radioligand therapy in any tumor at all. So that's very exciting, and we're very excited that this happened in neuroendocrine cancers, and we can potentially think about offering this treatment to our patients. So just as a primer for those of you who aren't aware, neuroendocrine neoplasms are divided into well-differentiated and poorly differentiated. Recently, we've further divided the well-differentiated neuroendocrine neoplasms into grade 1, grade 2, and now a well-differentiated grade 3. So this tumor group, it really has very slow-growing tumors and more fast, more aggressive tumors being the grade 3. So this therapy was detected in the high grade 2, and the grade 3s, the more aggressive subgroup of the well-differentiated neuroendocrine tumors. The key point is there's been no randomized study investigating the most appropriate first-line treatment. We often have been using somatostatin analogs or chemotherapy with the lack of clinical data in these aggressive patients. And this is the first study that actually defines a first-line therapy for these patients. So as I showed you, NETTER-1 established the role of PRRT upon progression. This trial was first-line therapy. Again, looking at advanced, well-differentiated grade 2 and grade 3 GAP-NETs, patients who had a Ki-67 of 10 to 55, so on the higher end of the grade 2. They had to have been diagnosed in the last 6 months and have had no meaningful prior treatment. They were then randomized in a 2-to-1 fashion to receive lutetium dotatate with maintenance octreotide versus, similar to the NETTER-1 trial, a high dose of octreotide in the first arm. They were stratified according to grade, the G2s and G3s, as well as the tumor origin, pancreas versus the other. There was a crossover arm that was allowed, and in fact, there is an extension phase of this study that looks at retreatment, but I won't get into that today. When we look at the treatment arms, it was fairly well balanced between them. We actually had a collection, it was a global study done around the world. And so we had patients of different races that were able to be included. When we look at tumor characteristics, really about half of the patients were pancreatic origin, which makes face validity because the pancreatic neuroendocrine tumors are the ones that are usually a bit more aggressive. And then we had small intestine and other, which were mostly rectum. A vast majority of these patients had liver metastases, as we would expect, because these were metastatic non-operable patients. And the ratio of grade 2 to grade 3 was about a 2-to-1 ratio, with a Ki-67 index margin of 17% in lutetium dotatate arm and 16% in the high-dose octreotide arm. So fairly well balanced, but also indicating that this was really more of an aggressive population. Most of the patients were able to complete all 4 cycles, 88% of patients, really indicating that this was well tolerated. And these were the primary analysis results. So looking at progression-free survival, it would improve from 8.5 months to 22.8 months, a hazard ratio of 0.276, or a 72% reduction in the risk of disease progression or death in those patients who got first-line lutetium dotatate versus those patients in the high-dose octreotide arm. Reassuringly, all the subgroups, both patient and tumor characteristics, all showed an advantage to receive lutetium dotatate first. What was really exciting about this trial specifically is looking at the response rate. So you remember we saw an 18% response rate in the NETTER-1 trial. In this more aggressive, highly progressive population, we were able to see here a response rate of 43%. And this is really exciting because it opens up things about thinking about neoadjuvant therapy, about patients with bulky disease. We're finding that we're able to treat these patients earlier and potentially treat them better. When we looked at quality of life, it was similar between arms. We didn't show any change in time to deterioration between the 2 treatments. And considering that this was a first-line trial, I think this is a promising result. Safety-wise, very similar to what we understand about PRRT so far. At the time of the first initial analysis, there was 1 case of hematological malignancy in MDS. I can say subsequently we've had a second case. So the numbers are consistent from what we've seen before. But again, this is early follow-up, and we're going to need to continue to follow up this data to really understand what is the first-line rate of MDS in these patients. There's a couple of other trials underway right now with PRRT and RLT in this in the neuroendocrine space that I think are important to mention. One is the COMPETE trial. This is being done by a company called ITM, and it has not been done in Canada, but a very important trial, which again looked at, similar to the NETTER-1, it looked at patients who had progressed on 30 milligrams or basically standard SSAs. The difference is they included pancreatic neuroendocrine tumors in these patients. They had a sample size of 300 patients. They were randomized in a 2-to-1 fashion to receive the lutetium dotatate here versus everolimus. This is ITM's product, which we don't have available yet in Canada. So this is delivered every 3 months versus Lutathera, which is given every 8 weeks. The comparison here was everolimus, which is another drug that we use based on previous trials. This study is completed accrual, and we wait till it to report. And the other important study is the COMPOSE trial. This is a very similar population to the NETTER-2 study, which looked at high grade 2 and grade 3 patients, first line being randomized to receive lutetium dotatate. The difference is here, the standard arm here is investigator's choice. It could be chemotherapy, it could be everolimus. And it's interesting because there was no standard therapy for first line therapy of these aggressive patients, people were using a hodgepodge of different therapies. This trial to me has really flipped because we know lutetium dotatate works here. We know PRRT works in this situation. What we don't know is how well chemotherapy works in comparison. And so this is going to be interesting. To me, this is really a trial about the efficacy of chemotherapy now. And in fact, what it has sort of led us to is we're waiting for the results of this trial. It is still undergoing recruitment. So we may hopefully in the next little while we'll have a readout on this trial. So the other big area that we've been particularly interested here at Sunnybrook at the Susan Leslie Clinic has been about retreatment with PRRT. So if we do give patients PRRT, what about more? Can we give more later? Can we retreat them? Because we give them 4 cycles generally. This was a meta-analysis that was done looking at a bunch of retrospective series, looking at retreatment, again, a very heterogeneous population, but they basically showed that the PFS is probably somewhere between 12 and 14 months for those patients who undergo retreatment. And it did show that there is not a huge signal, at least in this retrospective meta-analysis at MDS, which of course would be a consideration of the retreatment. So through the CCTG, we are leading through the NCTN, the National Cancer Trials Network in the United States. We are actually leading a retreatment trial called NE1, which looks at a trial of lutetium dotatate versus everolimus in midgut neuroendocrine tumors. This is really exciting. This is the first time that the CCTG has led an NCI trial in any GI cancer at all. So this is a very high priority trial for CCTG, and we're very lucky to be able to lead this out of Canada and have the Sunnybrook leadership that we do. And here you can see the schema of the trial. These are patients who right now have midgut neuroendocrine tumors that had a good stable response, which we defined as 12 months to initial PRRT. They had to have received at least 3 of their 4 cycles, and then they're randomized to receive 2 further cycles or everolimus, but they can cross over. I will say there's a couple of exciting developments here. One is we've been working with the NCI and have increased the CRADA funding quite significantly to the point where this will probably be one of the better funded cooperative group trials that we're going to see. And we are working towards also increasing a second cohort now of pancreatic neuroendocrine tumor patients that may be offered retreatment as well. So this trial is underway and a very exciting trial to see about retreatment. The other retreatment trial looks at alpha isotopes. So what we've been talking so far is about beta radiation. Generally we can think of these as causing single-strand breaks. There's alpha radiation, lighter particles, double-strand breaks, potentially more located to the healthy tissue, easier to dispose of and easier to administer. And a primary study that's looking at retreatment is a company called Raise Bio. They have an actinium-225 compound. They're looking at patients in a similar population. They're looking at all gastrointestinal patients who had at least 6 months response, so a slightly more aggressive population than our NET retreat study. And they're retreating them with either alpha radiation using actinium-225 or investigator's choice, everolimus, sunitinib, or high-dose octreotide, as we discussed. Unfortunately, this trial's on hold due to a shortage of actinium supply. And we actually do have this trial open here at Sunnybrook, and we have patients enrolled. But right now, the trial's on hold and we'll have to wait. So we have two retreatment trials actually going on here at Sunnybrook. This is probably a good time when we're talking about alpha radiation, just to share with you some hot off the press results. This is from ASCO last week. Another alpha radiation is lead. And this is a phase 2 study that these are the first results of lead radiation. We haven't had access to any of the lead trials yet in Canada, but I think this is something very interesting and we should keep our eye on as we think forward for radioligand therapy. So this is the Alpha Medics 2 design. This was a phase 2 study. It was an open label, multi-center study, prospective, evaluating the safety, tolerability, and efficacy of lead dotatate in PRRT naive as well as PRRT refractory patients. So they had two cohorts, people who hadn't received PRRT before and those who had in SSTR positive GAPNet tumors. Now, again, this is a very early trial, but I do think it's important to sort of highlight this because all the talk about alpha therapy, this is one of the first prospective alpha trials to come out. What they did is they actually combined and pooled the results of this trial where they had 36 patients, the first cohort of the PRRT naive patients, and the phase 1 trial they did to find the dose. So they actually combined those two to have an N of 44. When we think about the cohort 2, those retreatment patients, they just enrolled their last patient last week. And so we probably will hear about them, about this trial results in the months to come. So when we do look at the baseline characteristics of the PRRT naive patients in both the phase 1 and phase 2, we got 44 patients here, mostly pancreas, again, small intestine, so very similar to the studies I've shown you. They did have a mix of all grades, although primarily it was grade 3, and people were heavily pretreated, which would be expected in this population. And here's the efficacy that they've shown. I think the key point here is the high level of response rates we're seeing. So, we continue with each subsequent trial to improve our response rates. And the combined overall response rate in this phase 1 and phase 2 trial was 56.8%. Very exciting stuff. But again, these are very early, and I think we're all aware that when you look at a very sub-selected patients that qualify for a phase 1 and phase 2, you're probably picking the best of the best. So I'm very interested to see as this moves to a phase 3 if we can maintain these high response rate levels. But this is going to be very exciting about offering new options in terms of patients. When we look at the preliminary PFS and OS, again, very few numbers, but again, the progression-free survival was almost 75% at 24 months, and the overall survival was 90% at 24 months. From a safety perspective, interesting stuff. What we do know about lead therapy is it does cause some alopecia, and that can actually be quite debilitating for people, so we want to keep that in mind as we move forward. You'll see almost everybody on the trial did get some alopecia. There was some nausea and fatigue, and you can see with these high numbers, it's not specifically in this case the amino acid alone. They did see a fair amount of lymphocyte count decreased. We don't know the MDS rates yet, but we'll have to follow that. With 25% of patients receiving this lead therapy, having their lymphocyte counts go to a grade 3 or 4 toxicity, I think it's something we want to keep in mind. And the other thing I want to point out, which I don't think anybody was really expecting, was this rate of dysphagia. So all grade dysphagia, 1 out of every 3 patients experience dysphagia. And I don't think we've seen that with any of the previous radioligand therapies. So, in terms of safety, which I think was a key part of this, they saw 3 fatal adverse events. This was death due to underlying disease in 2 patients and multi-organ failure or sepsis in 1. I don't have the causal attribution for that case. As I mentioned, the hematological toxicity was grade 3-4. That was reversible, but we want to see if that's an indicator for later MDS. The alopecia, it was mild to moderate. It was mostly all grade. However, this does appear to be higher than what we've seen in other PRRT trials. And then the dysphagia, which they actually explored in some of the patients, and they thought it was achalasia and used some Botox injections at the lower esophageal sphincter, which seemed to provide relief. So still, excuse me, looking forward in terms of that. So that's sort of a whirlwind tour about where we are so far. a lot of questions remain, especially when it comes to retreatment. How many cycles should we be using? We have to balance the efficacy versus the toxicity. And, our trial that we're doing looks at 2 further cycles of retreatment. People think maybe we should be doing more. And I think that remains to be seen. But with the 2 cycles, we want to find out where does that efficacy to toxicity ratio lie. A really interesting piece of work that's coming through in all of radioligand therapy is, should this be dosimetry based? Should we be going to standardized dosing as would be given in many other systemic therapies, or is this going to be more based on dosimetry, i.e. tailoring the treatment to patients? And what about disease? Like, should we be giving the same dose to patients who have pancreatic, midgut, grade 3, grade 2? And what safety and toxicity considerations does that hold? And also, who should we be treating? So what is the optimal initial PFS response for retreatment? I showed you our trial that we are doing looks at a 12-month PFS response rate. The Action 1 study, which we're also participating in, looks at a 6-month PFS response rate, so slightly different populations. And if we are going to retreat, are there any certain prognostic or predictive factors that we should be using to drive this? So as we move forward, one of the other things we want to think about is, what about functional control? So in many of our neuroendocrine patients, if you join us on a Tuesday afternoon at our rounds, we're often talking about disease control and hormone control. We know that up to 25, 30, and in many cases, in some disease sites, up to 50% of patients are going to be secreting extra hormones. So is PRRT helpful in this area? So the NETTER-1 showed superior time to deterioration, as I showed you, but they didn't show that that there was an impact on hormonal control. However, when we look at other retrospective data in patients who had refractory carcinoid syndrome, RLT was shown to decrease flushing and diarrhea, which is a symptom of functional disease in neuroendocrine cancers, and was able to reduce the urinary 5-HIA, which is a breakdown product of serotonin, specifically in these patients, such that it makes you think that, is this going to be a clinically relevant way for us to be able to treat these cancers? This really gives you a plot, a waterfall plot of the reduction in 5-HIA, just to give you a sense that there probably is some role for PRRT to play in improving hormonal treatment, which probably goes along what we saw in terms of the improvement in quality of life, etc. So what about toxicity? So, we've talked a lot about the good. What about the bad and maybe the not so ugly? Well, toxicity is a consideration here. One of the big things that we're always considering is the long-term MDS rate. And so as we move forward on this, there was a systematic review that was done recently, which showed that in the long term, out of all patients, 2.6% of patients will develop a myeloid neoplasm. Now, there's a lot to be dissected here. We know that many of our patients in neuroendocrine cancers receive alkylating agents. There is some debate about about the interval between an alkylating agent and potentially radioactive isotopes, and maybe increasing that interval will reduce the MDS rate. There is some studies in Australia that do show that MDS rates can specifically go up with alkylating agents. Or is the sequencing important? If we give PRRT first or an alkylating agent first and subsequent use the other, does that in fact affect the MDS rate? So in patients who are heavily pretreated with alkylating agents, which have their own rate of MDS and PRRT, we're trying to understand what's the most safest and most way to maximize the efficacy of this treatment. As I mentioned, we've probably already decided that, or shown that the kidneys can be adequately protected with adequate amino acids. So hopefully that toxicity debate has been put to rest. But we still, continue to want to show in a large series here that was done, a retrospective series, so I didn't include the patients, but this is over 500 patients, that there was people who actually had some acute toxicity, but most of it seemed to recover within 3 months. And much like I showed you with the lead study, it seemed that most of the patients do recover their counts, but whether that indicates that the decreased precipitous drop in counts leads to an increased MDS rate later, we'll have to find out. Other specific areas specific to RLT that we want to talk about that potentially may be beneficial or harmful. A lot of patients with neuroendocrine cancer have peritoneal or mesenteric disease. We don't know at this time if radioligand therapy is helpful. The idea might be that the inflammation that may be caused and the tumor effect that may be caused with extensive mesenteric or peritoneal disease may actually become worse with PRRT. That being said, some of our most challenging patients, when I showed you those high response rates, some of our most challenging patients are those that have mesenteric or peritoneal disease, because unfortunately what happens with neuroendocrine cancers, it starts compromising blood supply to the GI tract. And when that happens, you start getting ischemic bowel. And very unfortunately, we've had some patients who die of ischemic bowel. And that is, I have to say, one of the most hard ways to watch our patients pass away. So if we can actually improve the outcomes here, this would be very important. So we have to be very careful when we treat these patients. But again, it's a bit of a two-sided coin, because these are the patients we really need the event for. So what we often do, sorry, I didn't put it down here, but we often do is we can use steroids to help, when we have these high-risk patients to be able to treat. So what I've shown you so far is where we are, a very expanding role of radioisotope therapy in neuroendocrine cancers. We have first-line therapy in the higher grade tumors. In the lower grade tumors, post-somatostatin analogs, PRRT, still trying to understand both the comparison to chemotherapy, as well as we're trying to understand the sequencing question and the combination question of PRRT, and potentially the idea now of retreatment and other forms beyond beta may be coming on the horizon. So a lot of role within neuroendocrine tumors to use radioligand therapy. So what can we do to make it better? How can we potentially, we're never satisfied with our outcomes in oncology, and we want to do things better. So what else can we do? Well, there's a number of different strategies that are be taking place, some here and some in other areas. First, if we start on this little clock here, you see the alpha emitters. I talked to you a little bit about that, but also where we bind to the SSTR2 receptor. There's now SSTR2 antagonists that potentially we may be able to attach radioactive isotopes to that may improve more than the SSTR2 agonists. There is ways of irreversible binding that people are looking at. So you bind there's a homeostasis that exists between binding of the radioisotope and the receptor. Where can we get to where we bind these close together? I talked to you about dosimetry. Coincidentally, SNMMI, the Society for Nuclear Medicine and Medical Imaging, is actually in Toronto, and I was there this weekend and attending some of the working groups around dosimetry and presenting there tomorrow. And specifically, they've asked me to talk a little bit about the medical oncology view on dosimetry, because this is really an area of uncertainty of which way to move forward on RLT, whether we use standard dosing or whether we do individualized dosimetry, which is a lot more labor intensive, but may allow us to be able to deliver higher doses to individual patients who can tolerate it safely. The doses of much of RLT has been based on standard organ numbers that we get from external beam radiation. But there was a really nice paper in JCO recently that sort of tried to refute how the rate limiting toxicity may be very different when we think of radioligand therapy versus external beam radiation, and we may be losing a chunk of efficacy in that regards. PET imaging, we try to use PET imaging. Gallium-68 detects if the SSTR receptors are on the surface of the cell, but we also want to look specifically at FDG imaging. There's a lot of data being done now for us to understand how that is, helps us understand this from a prognostic and predictive way. And then combination, as in other areas, radiosensitization, there's a number of studies being done with PARP inhibitors, triapine, chemotherapy to see if we can combine the treatment. We're talking about combining targeted molecular therapy, both IO and non-IO with PRRT. There's combination therapy, as I mentioned. Some people are using chemotherapy or alternating doses of Y90 with lutetium dotatate. And what's the role of somatostatin analogs? Does it always need to be combination like we've shown on these studies, or can we drop the somatostatin analog, which are both resource intensive, but also from a patient experience can be challenging. So really the issues we're starting to see on the PRT horizon, just checking on time here, are, is there a role for neoadjuvant therapy? I think this is a really exciting piece. We're seeing these very high response rates, 40, 50% response rates. All of a sudden we start to think about, can we make non-operable patients operable? The combination therapies I just described, there's some work being done on interarterial administration, so we can get the isotopes directly in, SSTR2 agonists, and then I described to you this new world of alpha. And there's a lot of debate about alpha versus beta, and maybe is there a sequencing or a better to alpha versus beta radioisotopes moving forward. So again, I'm going to skip by this because it goes into a bit of detail, but really it really shows you the different levels that are being expressed. Combination therapy with IO. We haven't been really successful at using immunotherapy in neuroendocrine tumors, and this may be a very exciting time. There's roles with embolization, roles with targeted molecular therapy. Do PARP inhibitors help? Can we improve the binding? And again, the role of alpha and selective treatment. So how can we improve patient selection here in moving forward? Well, there's different imaging as well as genetic markers that can be used. From an imaging point of view, we continue to look at the Krenning score, and Sten is presenting an SNMMI specifically correlating between Krenning score as well as the result of the PRRT in the NETTER-2 study to show that the higher the level of Krenning score, the better the results that we got in that study. There's SSTR avidity, which we may be able to measure quantitatively. And then there's this combination of using both gallium-68 imaging as well as conventional FDG PET imaging and looking at the discordance to be able to help understand. I'm going to show you an example of that in a second. And then there's numerous sort of algorithms measuring tumor scores that people are trying to validate to help us understand who are the optimal patients. What's exciting is there's a couple of genetic markers that are coming on the horizon called the PPQ and the NET test, both run by Ren Laboratories, that potentially have a lot of advantage in helping us understand who's going to respond to PRT. But first, I'm going to show you this work. This is done by David Chan. Some of you may remember he was a fellow here at Sunnybrook for 2.5 years, working in neuroendocrine neoplasms, and has now gone back to Sydney and has developed a very successful program in neuroendocrine neoplasms there. So it's great that we've had an impact at Sunnybrook about improving NET care around the world. This looked at tumor discordant volume, and this was discordant between FDG and dotatate PET. So seeing how much uptake was taken on the FDG or the sugar PET versus the gallium-68 PET. And what David showed very nicely in his work was retrospectively that those patients that had a higher discordant volume versus those that had low discordant volume did worse. So those patients who had a lot more FDG uptake and a lot less gallium did a lot worse than those patients who seemed to have non-discordant uptake. He actually looked at it via lesions, and he showed that if you had more than 2 lesions that were discordant in terms of your gallium and FDG uptake versus less than 2, your survival actually was impacted. And also, if you looked within the liver itself, that seemed to be where it mattered the most. So again, I think as we move forward, we're going to see more and more of this dual PET imaging helping us understand who these patients are and where they benefit. The NET test is a series of genetic markers. There's 2 of them we look at, the PPQ, which has been done again in some developmental cohorts in very small patients, no more than 70, but specifically looking at those patients who had a positive NET test. PPQ, pardon me, and showing that they seem to respond better to PRT, but again, these need more prospective validation. The NET test is a blood-based test which measures mRNA transcript expression of genes. There's 51 of them. And this is being considered to be used to help us understand the prognosis a lot better. And as you can see here, the NET test seems to be able to help predict with some degree of accuracy, the response that we're seeing between responders and non-responders. The other big area I just want to highlight is continuing the SSA. What we do now is we have patients who are on SSAs. When we start PRT, we do continue the SSAs, and the product label says to continue the SSAs for 18 months. We're not sure if this is needed. Some of you may be aware we have a cooperative research group with Australia and New Zealand called ComNets between Canada, Australia, and New Zealand. And we've actually got funding for our first global clinical trial through ComNets. And this is the trial schema. It's called StopNet. It's a phase 2 study looking at both the patients who are on PRT to continue with the somatostatin analog and to stop it. We're starting with a feasibility study, but the plan is to get this into a full-blown phase 3. And there is one trial that's being launched in all therapies, molecular targeted therapy, chemotherapy, looking at the starting and stopping of SSAs called the SAUNA trial. And that specifically will include a PRT cohort as well. So hopefully we'll get some more information on that. So with that, I will end and open to any questions, and let's hope for a better result for the Oilers tonight. So thanks very much. If you have any questions, feel free to ask, or please feel free to put them in the chat. Arjun? Arjun, can you hear me? I'm not sure if maybe he's having trouble unmuting. Monica, you have a question in the meantime?
Sure. So great presentation, Simron. Very exciting times in NETs. So I'm just going to ask, because as I was listening to your presentation and then sort of thinking about these sort of, let's say the grade 3 NETs that you have now included in your, most of those patients we wouldn't necessarily, well, maybe we might start with SSA, but SSAs don't really work. So I wasn't surprised necessarily by the short progression-free survival. But until you have the results of the COMPOSE study and those other studies comparing to more like other systemic therapies, what would you recommend people do? Like you have a, pancreatic NET with like a 67 of 35%. What are you doing in your practice?
No, it's a really good question. That's primarily been the area of discussion, both at ASCO after the presentation and other. I think when we come to the grade 3, well-differentiated neuroendocrine tumors, so again, the NETTER2 population looked at high, you had to be CRANING 3 or CRANING 4, high SSTR positive patients. So we had been using in some patients who had high SSTR suggestion to use SSAs. Chemotherapy, we know that there's probably some response. We just don't know how it is. There's never been a prospective trial of chemotherapy in this group. What I would say is for the grade 3s, I think, once we are able to, and once we have reimbursement and other things, I think PRT, at least for now, should be the first line therapy. I think the question comes about to those grade 2s, the high grade 2s. They may be patients that we can consider, depending on things like if we have any information on the tumor growth, the patient characteristics in terms of performance status and bulky disease. I think response is going to be important. That they may be patients where we may want to start on other therapies first and allowing for PRT post-progression.
I think those might be the cases good for discussion at the NET MCC, right?
Exactly. I think
we have those other trial results. It will be hard to know the right thing.
Yeah, absolutely. Arjun, you had a question. I don't know if
you put it in the chat. How dependent is supply an issue?
Interesting question. When we were doing the NETTER2 trial, there was some manufacturing issues that put the hold to the trial as well. Those are manufacturing issues, and I think they've been very well sorted out. Supply still continues to be, how we think of the supply is more, I think, a process issue in terms of many of the isotopes. This is a new way for us to be able to treat cancer, so we need to think of what those resources are and what exactly the processes are, as opposed to a treatment that comes in a box that we just need to temperature control. Actinium has had some supply issues. There's been attribution to, the situation between Ukraine and Russia, but really, I think it's just really the ramp up. There's been a lot of batch failures with actinium, and then so hopefully those supply issues will get sorted out. But I think from those perspectives, I know I'm not sure from a isotope. I know you may have a comment in terms of Ontario and the role that Bruce Power is playing in isotope generation. I think this is going to be a big area of growth, and hopefully we'll be able to get past some of the acute, hiccups that have occurred in supply issues. I think he put in his chat, I think there's a concerted effort that you can advocate for. Absolutely. I think, this is something that, we want to make sure that we have, they've disabled our mics and video. I don't know if Arjun, if someone can, if Arjun's has been disabled, if someone could open it, but um, I think, yeah, I think you're absolutely right. I think as we move forward, isotope therapy, both the actual isotope generation itself will have to be considered, but also I think at a provider level, we're going to have to think about how do we manage the resources that are needed to stock these sort of treatments, to keep them, to be able to receive them. I think those are all new areas to consider, especially as we think about, as this comes about for other tumor sites, Pluvicto for prostate and otherwise. NETs is just really the start of this. Okay, if there's no other questions, if anybody has any questions, feel free to drop by and ask me or email me. But otherwise, thanks for the opportunity. And yes, go Oilers. I totally agree. Thanks.